Dear colleagues, congratulations to all of you because you have made your work through to the paces. And as you know, you might be surprised to hear that paces happens to be the easiest part of the entire MRCP membership curriculum. If you are amused to learn that, let me tell you that ever since I have appeared in the membership exams, I have participated as an examiner, as a trainer. I have found it's the easiest path to get through, to crack through, because if you just follow certain rules, if you just practice hard and practice repeatedly, paces is just a cakewalk. I have put up the MRCP carousel, paces carousel, which is just a representative of what a carousel might be. The carousel might come in surprising combinations. Click, please. The next one. Yes. So you can see it's almost the same, only a little bit of different in combination. So anything can be your station 1, anything can be your station 2, anything can be your station 5. So don't be under the impression that abdomen will always appear in your station 4. It might not be so. It might not be abdomen, it might be communication, it might be something else. So, abdomen is an important station, it's a 10 minutes session. But also do remember that when you are doing a brief clinical consultation, you might also be required to examine the abdomen as fast as possible. But that is not what we are discussing today. We are discussing abdomen as a station, how to go through, how to examine the abdominal system or the GI system, uh, particularly to fit into the shoes that they want you to wear for paces. Next one. So, what are the common encounters in the abdominal station? So, certainly this list is a representative, and these are the cases that commonly keep coming up for the abdominal station. But these are not all. You might find other combinations. You might find very bewildering combinations or a very rare disease that has been put up due to the paucity of actual cases. But let me tell you that every convener, every examiner, every center is very particular about bringing in the prototype cases, which they want the would be consultant, the would be medical consultant to be conversant with. So there is 90% or more chance that you will get the common encounters, but they may come in varied combinations. So in renal diseases, you get renal transplants, you get adult polycystic kidney disease. I mean the ADPKD, autosomal dominant polycystic kidney disease. You might get a now, here is the twist. You might get a patient who is neurologically compromised due to a stroke, and yet the patient is there in the abdominal station. So, these are the twists that you should expect. Now, you might have a patient with chronic kidney disease, you might have a patient with a nephrectomy scar. Next one. Next, probably is the hepatobiliary system. You might get a chronic liver disease with or without a liver transplant. You might get a cirrhotic patient, the commonest of the hepatobiliary as well as the abdominal cases. You might get a acute liver failure for varied reasons, the commonest being paracetamol overdosage, and you might, in a lesser proportion of probabilities, get a hepatocellular carcinoma. Next, please. You have a splenomegaly and splenectomy kind of coming up very commonly in our country. If you are appearing for a center which is there in India, there's higher chance that you might get a splenomegaly case, and this is one of the easiest encounters and the most difficult to pass as well. Next. Next are the miscellaneous conditions. Other relevant conditions like vague abdominal pain, ascites, abdominal aortic aneurysm, very rare. Abdominal muscles, quite common. Small bowel obstruction, very, very rare again. Inflammatory bowel disease in remission. You wouldn't get a very acute inflammatory bowel disease. Then you get a pancreatitis, usually a chronic one or an acute on chronic one. You might get a cholecystitis, usually with or without gallstones, but then again, it's a chronic calculus or acalculous cholecystitis. Gastroesophageal reflux disease, they'll give you GERD only if they don't have any good cases. And finally, gastritis or peptic ulcer disease. If you have got one of these last two, be very, very particular, be very, very meticulous, because your passing would be more dependent on how you examine the patient and how you tell your DDs. Next. So we are now approaching the patient. So, as you all know, introduction is very important. You have to introduce yourself. You should elicit the name of the patient, the age, and the occupation. One good way of doing it is telling the patient his name or her name, the age, and get it validated from him or her. Or you can have an open question like, I'm Dr. Swan, so a house officer looking after your case today or looking after you today. May I check your name and age? Never say what is your name, because you are supposed to know the name of the patient. So you are either checking or validate. Next is you have to explain the examination to the patient and seek consent. Tell him or her that I'm going to look after your tummy. I'm going to take a look at your tummy. I'm going to look at your the organs inside your tummy. I would look at it. I would have to touch it softly and then a little bit deeply. And I might also do a little one or two maneuvers or one or two procedures on you to find out the right findings. And you have to position the patient. We'll talk about that in a short while from now, but ensure that the patient is lying flat or a little head up and the patient has been exposed appropriately, but exactly the portion that you wish to examine has been exposed and nothing more than that. Offer chaperones for both female and male patients. This is something that you should remember by heart. Do not forget asking for a chaperone in case of a male patient as well. You should wash your hands, or better, you have to sanitize your hands. And if there's a oozing wound, say you have an abdominal scar which is oozing pus, if you examine that, you have to sanitize your hands and ask for a pair of gloves. Next. So you start off by a general inspection, usually by looking at the patient from a distance. There might be a very crooked examiner who would deliberately turn off a light inside the room, making it difficult to examine. So you have to ask for a, if you find it awkwardly dark, if you find it awkwardly underlighted, under illuminated, clearly ask the examiner if there's any second light in the room, or if you can arrange for a light, and they will definitely turn on one which they have deliberately turned off. You look for the scars, you look for a distension which is obvious, you look for masses, you look for a stoma, ileostomy, colostomy, or a gastrostomy, feeding gastrostomy with a peg tube. You should look for hernias, you should look for any discoloration, jaundice being one of the many, and indwelling catheters, if any. Look for any movements, including gastric peristalsis or pulsations. Describe the abdominal contour as flat, scaphoid, which essentially means sunken or protuberant. Next. So I guess these all of you know, these are the different type of scars. You should remember them by heart, because if you fumble, if you fail to identify a very typical scar and you would be given a very ideally looking scar, then you're certainly going to fail in that station. You're going to fail the entire examination. Scar is so very important. Or if you fail to identify between an ileostomy and a colostomy, or if you miss something like the icterus, the deep icterus in the lady at the bottom left, or you miss an obvious swelling like a hernia, or a bulging aneurysm. Next, these are common findings as xanthalasma, but not so common with parotid enlargement. But you might get a parotid enlargement commonly with a if the participants tell me, where do we usually get a parotid enlargement in case of a uh, abdominal examination? Where do we expect that? Anyone?
Chronic alcoholism.
Yes, absolutely so. And if it is as very obvious as this, you cannot afford to miss it. Next, Fatma, you need to change. Yes, thank you. So you should also not miss things like a cervical lymphadenopathy, particularly a Verkau's node in the left supraclavicular fossa, a quite obvious gynecomastia, and in certain cases, do not miss the loss of hair or paucity of hair on the skin. Next, you should not forget examining the hands. In most of the stations, examining the hands is a very important component. If you miss it, you miss out everything. You should look for the C's. Like in clubbing, the C's are related are cirrhosis, celiac disease, wouldn't get one. You might get a Crohn's disease or an ulcerative colitis in a very quiescent and peaceful state. Look at the nails for leukonychia. Uh, you might get such whitened nails in chronic liver disease, cirrhosis, or hypoalbuminemia, spoon-shaped nails like koilonychia, and many others. Look for palmar erythema, which is so very obvious in chronic liver disease. Feel for a Dupuytren's contracture. Don't think that Dupuytren's will always appear very visibly on the palm. You might accidentally stumble upon one which is subtle developing, and for that you need to touch the patient's palm and also check for flapping tremors. Next. These are examples. As you can see, there's clubbing, there's subingual hemorrhage, there's Dupuytren's contracture, palmar erythema, leukonychia, and koilonychia. Next one, please. In the face and the body, you look at the eyes for signs of jaundice and or anemia. Can anybody tell me a particular disease where there is anemia, abdominal station where there is anemia, and yet there is no sign of jaundice? There is anemia, but no jaundice, because jaundice with anemia, quite obviously, there's hemorrhage from the GI tract, but there's no jaundice, but there is anemia. Where do you usually find it? Can we find a case of chronic liver disease where there is no jaundice and yet there is anemia?
Hypersplenism.
Sorry,
Hypersplenism.
I'm not getting you. I'm so sorry.
Hypersplenism.
Hypersplenism, that's one good guess. What else? Anything else you can think of?
Chronic kidney disease as a result of polycystic kidney disease.
Well, you see, these are absolutely right guesses. You can also get a case of simple gastritis or a erosed um, duodenal ulcer which has bled and which has basically given problem to the patient. There has been blood loss, but that was not essentially of hepatic origin. You would look around the lips for brown freckles. Very rarely you get them. Inspect the mouth for central cyanosis, glossitis, macroglossia, uh, dry tongue. You need to look for ulcers and certainly the breath. Inspect the trunk for striae, signs of chronic liver disease, the Cullen's and Great Turner sign. I don't think they would give you a pancreatic hemorrhage case, and you can rest assured that you wouldn't be tested with something. Yeah, sorry. I got disconnected. These are the findings that we were talking about. On the top left hand corner, you get a aphthous ulcer, you get a severe stomatitis, you get prominent anterior abdominal veins, gynecomastia, and the hemorrhagic spots on the abdomen. Next one, please. As I said, we'll be talking about positioning. For all practical purposes, we know the anatomical quadrants of the abdomen, but abdomen can be divided into four arbitrary quadrants for easy palpation mapping. The patient should be lying down, ideally supine. But if you find that the patient is very tensed, the abdominal muscles are taut, you might ask the patient to rest the hands on his or her chest or by the sides and fold the legs at the hip joint and the knee joint. That does not anatomically help the patient, but it certainly helps them alleviate anxiety and the muscular tone goes down. So the patient should be on a couch with a little bit of elevation in the head, if at all, or you can ask the patient to be comfortably supine. Remember that your hand and your examining eyes should be in the same level with the abdomen. So, standing, looking from top and palpating the abdomen is usually not looked upon in the right spirit. So, while palpating, you should ask for a tool or a chair on which you might sit, or you might be comfortable doing it your own way by folding your knees, squatting or half squatting, and finishing off in the right perspective. Next one. So once you have uh, done this, once you have positioned the patient and the patient is supine on the bed, you should do a quick inspection again. Yes, again. Don't take more than 10-15 seconds because you have already skillfully examined the patient, observed the patient. But while you inspect, these are the things that you cannot miss. Look at the shape and movements. Look at the scars again. If you have missed one, you might have a very thin scar that has changed its color over years. It has atrophied and it's just like a shiny hairline on the flank. Don't miss it. You might find distension, you might find prominent veins, striae, bruises, pigmentation, and yes, you might find visible peristalsis. A trick to be remembered in pyloric stenosis, such visible peristalsis is usually left to right, and so is with large intestinal obstruction. With small intestinal obstruction, the visible peristalsis comes in bits and parcels. We say short cocktail sausage swellings at different parts of the abdominal wall. Next, this is how you palpate. Definitely not as shown in the picture. Lower down yourself and bring your eyes as close to the examining surface as possible. Ensure that your hands are warm. You should stand on the right side of the patient if you are a righty, but if you have a right uh, hemicerebral domination, that is, if you are a lefty, you can jolly well stand on the other side. But it also largely depends on how the bed is placed. You might find a bed deliberately placed in a way that you cannot go to the right hand side of the patient. You cannot move the patient will refuse. Make sure that you do it properly from the left side. But these are very rare situations, I'm telling you, so that you are not taken by that element of surprise. Ask whether the patient feels any pain before you start. It's so very important because those are the areas you'll palpate or percuss last. Those are the areas you'll be most gentle with. So you should begin with superficial examination, move in a systematic manner through the abdominal quadrants that we have discussed, and thereafter repeat the palpation deeply. Next. Now this is the light palpation. You put the pulp of your fingers. Look, your wrist is at the same level with your fingers and almost in a horizontal parallel with the abdominal wall. But once you move for deeper palpation, you can put the pressure in two different ways. One is you can deepen the pressure with your examining right hand, or keeping the right hand intact, you might prefer to put pressure with your left hand for the deeper aspect of the palpation. But remember, the same topographical journey has to be followed, covering all quadrants, knowing very well which organ to be covered in which quadrant, and thereafter finishing it off in again less than 30 to 40 seconds time. So just do not keep on palpating if there's nothing in particular. Be confident, be in yourself. Next. So you should, this is probably an overstatement. At this stage, you don't feel for the Virchow state. Uh, Perform deep palpation, feeling for the masses. So if you find a mass and if you're confused whether it is a liver or a liver abscess or a pancreatic pseudo abscess or something else, just very methodically assess the size, the shape, the age, the consistency, the percussion note, the bowel sounds and thrill or deep tenderness. Abdominal distension may be caused by ADFs, fat, feces, fluid, flatus, fetus, full-sized tumors, much like this, and full-sized bladder that has not been properly emptied before the examination, and certainly a large neural fibroid. Next. So, what do you look for in palpation? Well, every time you palpate, look at the face of the patient. Make it a habit. Look at the facial expression of the patient. You look for tenderness, which is discomfort and resistance to palpation. However, there might be a severe pain causing reflex contraction of the abdominal muscles, which is guarding. You might have an involuntary guarding, you might have a voluntary guarding when the patient feels typically ticklish. You might have a rebound tenderness where the patient feels pain when the pressing hand has released the pressure. You might also have a tenderness and the rigidity confirmed by your colleague in case of a perforated viscous, palpable mass, and aortic pulsation. Aortic pulsation, if present, I mean pathologically present, then you are not supposed to miss it. Two fingers in the midline, assuming the position, midline position or quasi midline position of the aorta, and you're not going to miss it. Next. So these are some signs that you should look for as well, or just go on with the commentary saying that there's no Rovsing sign, there's no Murphy's sign, since the patient is in the right upper hypochondrium, right iliac fossa mass has not been assessed after deep palpation. So you can go on with this commentary. So the examiner exactly knows what you are looking at, what you are looking for, and that you know what you are uh, looking for in palpation, or what the abdominal, intra-abdominal anatomy is from the surface. Next. So, palpation of the liver is where you may or may not flex the knee joint. Ask the patient to take a deeper breath in. Start palpating in the right iliac fossa. Move hand progressively further up the abdomen, keeping the hand, the index margin of the hand parallel to the contour of the lower thoracic line, and I mean the lower border of the last thoracic rib, and finally try to feel the liver edge. Once you have felt a liver edge, it is certainly enlarged. You're not supposed to feel a liver edge. And once you have done that, you should check for the liver span. Next diagram shows how you exactly do a liver spanning. So the idea is that if the liver grows, if the liver enlarges, it grows downwards, which is why you can feel it, but it at the same time will grow upwards and push the diaphragm a little bit on the upper side, move apartly or apparently indirectly it invades or takes up space inside the liver, inside the thorax. I have had cases of liver abscess where the patient has initially developed pleural effusion, and then the abscess have enlarged like anything and encroached onto the liver, onto the thorax indirectly. So it will enlarge upwards, and so you need to do the spanning, the upper border of the liver. So you should palpate right from beneath the collarbone. Keep on percussing, come downwards in between the ribs in the intercostal spaces, and find where it goes dull, whether you find that the liver span has actually increased upwards as well. Before you start percussion, it is customary that you do a blank percussion on a rib to feel or find out the tone on the ribs as well as in between the ribs. If you have time, you do that. If you don't have time and you're confident about percussing, just go and do your job. At the same time, when you do this, the examiner might clearly tell you, you need not do this. If the patient is uncomfortable, the examiner might say so, or the examiner might be kind enough to save a small amount of your time. If you are not sure whether you have palpated the liver uh, in the abdomen, it's actually not very essential doing a liver spanning and spending your valuable time. Next. So this is how you palpate the spleen. It is by manual palpation. Initially, you roll the patient towards you, start the right side from the right iliac fossa, palpate with right hand while using the left hand to press forward on the patient's lower ribs from behind. You might do it initially without going by manual, but since you have to do by manual, since you are bound to lose out on a very important finding without doing so, it's good time saving technique to do it right at the beginning. Next. So this is another bimanual palpation, palpating the kidney. It's important that you don't ask the patient to elevate the flanks. You tell them what you're going to do, that I'm going to put one hand under your back and with the other hand I'm going to try feel your kidneys. If the patient does not raise his or her hip, you must almost be sure that this patient probably has a low back pain or something of the sort that is basically preventing the patient, him or her, from obliging with a lift. So, in that case, you just insinuate your hand under the desired area and do a palpation. But remember, it's very difficult to feel if the kidney is of the right size or even smaller. Next, the fluid thrill is when you place the palm of your left hand against the left side of the abdomen, flick a finger against the right side of the abdomen, ask the patient to put the edge of a hand on the midline of the abdomen, or ask one of those student observers to do it. If a ripple is felt upon flicking, we call it a fluid thrill, which is indicative of free fluid in abdomen or ascites. The very important part of doing a fluid thrill is that the pressure in the midline. Otherwise, with a modestly large uh, fluid accumulation, you might still miss it. Next. So in percussion, you look for dull sounds, you look for resonant sounds, structures containing air or gas which look more lively, and you get shifting dullness. Now, the percussion methods are written out there on the right hand side, but do remember that shifting dullness, wherever necessary, should be done in the right manner. Like you should remember that next, shifting dullness is all about a little bit of physics. There's a tympanic zone. Next, please. And the resonant zone. As you can see, the tympanic zone is towards the upper part of the abdomen. Since on lying down, the fluid gravitates downwards, so that will be dull. What you do is you go percuss and find out the dull spot in the on the flanks. You turn the patient and then you do the percussion again, only to find out that the dullness has as if shifted. It's not that. Do remember to wait for a few seconds, like 10-15 seconds, before trying to do the shifting dullness demonstration, because the fluid has to gravitate down to the dependent side, and if you don't do that, you're going to face questions. Next, finally, auscultation. Don't forget to carry your stethoscope while entering the abdominal station. I remember a colleague of mine, and he had just left the stethoscope on the waiting chair and table that is outside of a station, and finally couldn't do this auscultation part in his abdomens. You have to place the diaphragm, not the bell, the diaphragm of the stethoscope to the right of the umbilicus, and try to listen to bile sounds. And they are caused by peristaltic movements. They occur every 5 to 10 seconds, and absence of bile sound, confident absence of bile sound, usually relates to paralytic ileus or peritonitis. And the bruise over aorta and renal artery could be a sign of an aneurysm or stenosis, which, if present, should not be missed. And I'm sure none of you are going to miss it out. Next. Now, normal sounds are due to peristaltic activity, which is a progressive aboral wave-like movement that occurs involuntarily in hollow tubes of the body. Listening is essential for 15 to 60 seconds. Before you say, I would say 60 seconds is much too much. Spend no more than 20 to 25 seconds. If you don't find any bowel sound, quickly change the spot and try for hardly 10 seconds more. Now, bowel sounds shouldn't sounds cannot be said to be absent unless they are not heard after listening for 3 to 5 minutes, and that is to be mentioned. Like you're not going to wait 3 to 5 minutes before you declare that there's no bowel sound, but you can certainly say that currently I do not get any bowel sound, but I would like to re-examine the patient about 50 minutes later or 45 minutes later down the line. There are three things about bowel sound. First of all, are bowel sounds present? Number two, if bowel sounds are present, they would frequently be sparse in quantity, or they have a peculiar nature of the sounds. Like uh, you might have a rushing sound, might have a normal peristaltic sound, or you might have a tinkling sound. Usually in diarrhea, what we see is a diarrheal illness or a paralytic ileus, and the bowel sound is returning to normal. We see that initially there's a rush, or there's a normal bowel sound which is replaced by tinkling in case of a pathology. So do listen, but not too much, and try to appreciate so that you can detect a bowel sound in difficult situations. So only practice will help you learn that. Next. So we are towards the end part of the story. So never forget to mention, even if you don't do. Those are two things. One, I would like to examine the hernial orifices. You might not be as lucky. A patient with a uh, large ascites, you might be required to do and not only say, because in such cases, an inguinal scrotal hernia is quite common. And definitely do not forget to say that I would like, or I wish I could have done a rectal examination, but uh, right now the patient is not comfortable with in the presence of animals, or you might prefer to do a prerectal examination, upper rectal examination at a later date when the patient is comfortable. Remember that a rectal examination, even the inspection part, you are not supposed to do. Previously, in the OSCEs, you were given a dummy to find out your skills on that, but these days we do not do. If you quickly browse through this part, you are saved. If you have examiners like I had someone called my Gahir, he used to immediately pounce upon the student and ask him that what non intestinal or non GI organ do you palpate while doing a rectal examination. So, any quick answer on that? Which organ or which part not belonging to the GI tract we palpate while doing a rectal examination?
prostate,
Yes, and in females, other pelvic organs, right? So before I ask Fatma to give a last strike on her mouse, anything that you do at the conclusion, any comment, concluding remark that you make before closing your examination? Well, then the next click will tell you, Fatma, you should express your willingness or your wish to do a urine dipstick and look for edema, even if you have not already looked at it. Then only mention that I wish to collect a urine sample, have a physical observation, and do a urine dipstick. That actually completes and concludes your examination of the abdomen. So, my slideshow ends here. And before you people can ask questions, let me also tell you that once you are examining, you should prepare yourselves uh, for the next part, which is the question and answer. The quickly you finish off your examination, the more time you have in answering questions, because remember that presenting your case, coming up with a provisional diagnosis, giving a DD, outlining a way to close in on the right diagnosis, that is the right set of investigations, and an outline of management, everything will fetch you points, will fetch you marks. Nobody is going to ask you every detail about a disease condition or of the patient. So you should save yourself time. And as you go through examination, prepare a summary. If you have a good examiner, now most of the examiners are good and well trained, If you have taken up a lot of time while examining the patient, they will straight away ask you what is your diagnosis. But if you have saved enough time, they would start off with a easier job asking you to what is your case, or please summarize your case, or please present your case. So here you have some time before you are confronted with the critical question, what is your diagnosis? Somebody might not go to the DDs at all. Don't be afraid. If the examiner has not asked you DDs, you will score on that. That's his lookout. And remember what my first MRCP PACES convener said, that I know all of you are tensed, but remember the examiners are twice as tensed as you. Because if you fail to identify a sign, you'd have another chance at the examination. But if we find that you have performed well and the examiner has failed to identify you as a potential candidate to pass, that examiner would never feature in any other MRCP examination throughout his entire life. So that is something very important. No examiner is sitting there to give you a fail mark. And if you have done something rightly, if you have comprehended yourself rightly, there's no reason why you should not get through it. So these are the questions that are usually asked, and if you're outstanding, you might have only one question asked, like what is the diagnosis and how do you establish your diagnosis. Don't worry about the questions not asked in between. Even though the mark sheet is well designed, uh, it is in such a manner, I think all of you have seen the marking sheet, that you get points for everything you do. But if, once again, if your examiners just bypasses a certain part of the scoring questions, you are sure that you're going to get a clear pass on those. So do not panic, do not be tensed or anxious, just be yourself and face the questions at the very basic level. So I'll stand my points here, and if you really have a question, I have an answer to that, I'd be happy to face.
Hello, sir.
Yes, I can
Sir,
hear you during examination. Yes,
during
be
examining
louder, please.
during examining the patient, can I ask for any relevant history from the patient, or it is just no talking with the patient during examination?
Absolutely no. What you can do is you can just ask the patient, like before deep palpation, that now I'm going to press upon your tummy a little harder, and I'll certainly avoid the points where you have pain. Let me know if you are uncomfortable. That is all you tell the patient. Please do not ask anything from the history. That is not only going to steal away time from you, that is again the examiner would ask you not to. That is good. If the examiner doesn't tell you anything and you keep on asking history, that is going to be reflected upon your marking sheet.
Thank you, sir. So another question is, do we need to examine the test case in proton during the abdominal test? Do we need to
Well,
examine?
it's if it is a clear case of if it is a clear case of an inguinal scrotal swelling, you need to cover up the patient, you need to curtain the patient, you need a chaperone for that. But I haven't ever heard of somebody being confronted with uh, inguinal scrotal swelling that is rather in MRCS stations. You will certainly say, as I said, that I would like to examine the inguinal, I mean the hernial orifices. That shows that you know that you are supposed to do it, but I don't think you need to do it. In case of a chronic liver disease, well, testicular atrophy happens in 29 to 37% of cases. I don't think somebody is going to mind much if you've done everything else right. If the examiner is intentful, he might ask you that, did you in the abdomen? You might say, yes, sir, I would wish to examine the inguinal scrotal region. and I would look for testicular atrophy in this patient. Or if there's a huge ascites, I would hydrocele. Uh, the examiner will know that usually you are not expected to do a testicular assessment.
Thank you, sir. Another thing is, do we need to comment on the back of the patient during the inspection phase? If the patient is lying down, can we ask him to sit up and maybe let us examine his
Yes,
back?
of course.
And we can ask the patient to sit
Yes,
up.
at the end of the examination, you are supposed to cover. Yes, sit up, look at the back, look for sacral edema, help the patient to lie down, cover him, thank him for his cooperation before you face the examiner. The examiner will always be on the other side, looking at you most indifferently. Do not make an eye contact with the examiner till you have finished your examination, because that is dangerous in two ways. One, you would be immediately having some effect from his way of looking. Have I done something wrong? Am I missing out on something? So don't do that. And second is, you are supposed to look at the patient when you are examining the patient. So you cannot really look at the examiner during that point of time. So once you have done your examination, look at the back for sure. If you have time, elicit sacral edema just for a second or two. Allow the patient to lie down, ask him if he was comfortable, thank him for his cooperation, cover him, take one pump of sanitizer in your hands, and face the examiner. That's a perfect, confident way of doing it.
And so, you suggest which book we can follow for these clinical methods examination if we want to read upon. So can we follow the
You need to speak louder. I'm sorry, I'm missing out on that.
So, which book can we read upon just to consolidate our ideas about these examination procedures? The MacLeod's, is it fine, sir?
I think you will. You already know about a host of books, starting from Cases
Okay.
for Paces to Timothy Hall, various books.
Okay.
Find out the book you like most. Find out the book that helps you most, and take that. And I bet all of you know how to get access to the past test videos. Well, there are
Um,
numerous Telegram channels where you can find videos on examination, PACES examination. I would particularly also ask all of you to do a short subscription of a site called Geeky Medics, GEEKY, Geeky Medics. It is available on YouTube. It's not very expensive, rather inexpensive for a basic examination idea of examining a patient. That is marvelous. That is excellent, especially things like neurology and cardiology, to get the basics right, to know how to examine the patient. Now, definitely, it is not like OSCEs, that if you do your procedures right, if you do your examination right, you score a lot of points. Here, you do need to identify signs and know how to manage them as well. But geeky medics give you a lot of confidence that you can finish off the examination in 4 to 6 minutes flat if you practice it well. You can try that. And books, Cases for Paces is excellent. Uh, Even you have to fall upon a little bit on your part one notes and part two notes wherever necessary. Fatma, I guess there's no more question.
Yes,
So I thank all the participants for their patient hearing. If you have any other question, you can pick up my WhatsApp number from Fatma. You can send me a voice note. I'll try to help you out as much as possible. Best of luck for your examination. I'm telling you, this is one of the easiest, not one of the easiest, this is the easiest part of the MRCP curriculum, the MRCP series of exams. So make the best out of it, go confident, and just follow the 1, 2, 3, 4, 5, 6 rules, and you will be uh, getting very, very good marks on your sheet.